Welcome to the Funnel Effect. We are diving deep today into, well, really one of the most exciting and you could say disruptive shifts happening in interventional cardiology. It's this move toward metal-free treatment for coronary artery disease.
Wow.
Our focus, it's the rise of the drug-coated balloon, or DCB, as a truly foundational tool. And the roadmap for this revolution, it comes straight from the experts. Our deep dive today is built entirely upon this key paper, Drug-Coated Balloons-Based Intervention for Coronary Artery Disease. The second report of Asia-Pacific Consensus Group, it was published just recently in JCC Asia, that's volume 5, number 6, in 2025. And this consensus, it represents a massive collaboration. I mean, it's a powerhouse team of leading cardiovascular specialists from right across the Asia-Pacific region. You've got names like Yi Young-Her, Wan Asman, Wan Ahmad, Lu Hongbang, Ong Tiong Kiem, Aminarif Nordin,
Changshe, Hohiwa, Sheful Azmi Ahaya.
King Tang, Dongqing Su, Chim Guang Q, Jikan, Rosli Mod Ali, and Yoon Seok Shin. 14 authors in total, really shaping this new direction.
That's right. Very comprehensive group.
So our mission today is pretty clear. We are going to unpack these new Asia-Pacific guidelines, and they dramatically elevate DCBs, don't they? They're positioning them not just as, a niche solution for certain problems.
Right, not just for restenosis anymore.
Exactly. But as the default starting device in quite a few percutaneous coronary intervention, or PCI, procedures. So we really need to understand the specific clinical scenarios, the anatomical situations where DCBs seem to offer superior outcomes. It promises a future with, well, less metal and maybe shorter recovery times for you, the patient.
It really is a true paradigm shift. I mean, the focus is moving away from optimizing a permanent implant, right? The drug-eluting stent, or DES, which we've relied on for years, to optimizing the vessel itself. And the core advantage of DCBs, the thing that makes them this groundbreaking sort of stent-free alternative is, well, it's eliminating the risks that come with leaving a foreign body behind permanently. Specifically, we're talking about avoiding that persistent threat, however small, of late stent thrombosis and, crucially, in-stent restenosis, or ISR. If we can solve the blockage problem without creating a new, lifelong metallic commitment, well, that's a massive potential win.
Okay, let's unpack that a bit because, we've all gotten very comfortable with the success of drug-eluting stents over the last couple of decades. They are, engineering marvels in many ways.
Absolutely. They revolutionize treatment compared to bare metal stents.
But if we look closely at the long-term data, what exactly is the biological problem that even the best DES creates? What's the lingering issue?
Well, the problem isn't usually acute failure. It's more of a chronic vulnerability. While DES do a great job preventing that aggressive initial tissue overgrowth, that neointimal hyperplasia you saw with older bare metal stents,
right,
the permanent presence of the metal struts, the polymer coating, and sometimes the drug itself, it causes this chronic sort of low-grade inflammatory state in the vessel wall. And our source material, this consensus report, is pretty blunt about the consequences. Even with the best contemporary DES available today, there is a persistent annual risk of recurrent events. We're talking restenosis or late stent thrombosis of nearly 2% every year.
Wait, did you say 2% annually? That's the really striking part, isn't it? Because I think most people, patients included, assume if you get past that first year or so post-stent, you're basically in the clear.
That's the critical insight, really, that's driving this whole shift towards DCBs where appropriate. The risk does not plateau. It just keeps going. And this sustained vulnerability, well, that's pretty much the definition of the chronic foreign body response. The stent, just by being there, disrupts the vessel's natural healing processes and its ability to function normally. Its vasomotion, the ability to dilate and constrict naturally. Over decades, this can lead to something called neotherosclerosis, which is essentially new plaque forming inside the stent itself. So it kind of perpetuates the risk you're trying to treat in the first place.
And I imagine this vulnerability gets amplified, right? Especially when the disease is already complex, maybe needing more hardware, longer stents, overlapping stents.
Absolutely. When interventionalists are dealing with complex lesions, particularly in small vessels, say less than 3 millimeters, or lesions that require very long, maybe overlapping segments of stents, the clinical outcomes tend to become suboptimal. The more metallic scaffolding, you introduce what we sometimes call the overall metallic burden. The higher the risk of mechanical complications down the line, incomplete vessel healing, and just subsequent stent-related problems. It can become a bit of a vicious cycle, almost metal-on-metal issues.
So the DCB solution, it's summarized really beautifully and simply by that phrase in the report, leave nothing behind. It sounds fantastic in theory, but How does a quick, 1-minute inflation truly treat a chronic disease like coronary artery disease effectively?
It's actually quite an elegant solution
Yeah.
centered on pharmacokinetics, how the drug behaves. The DCB is coated with an anti-proliferative drug. Traditionally, it's been paclitaxel, mixed with an excipient, which is basically a carrier molecule. During inflation, which, as you said, lasts for at least a minute, usually 60 seconds or more, the drug is rapidly and hopefully uniformly transferred directly into the vessel wall tissue.
Okay.
And then, crucially, the balloon is immediately deflated and removed. The drug stays behind in the tissue to suppress that proliferative response, the scarring or overgrowth that happens naturally in response to the injury caused by preparing the vessel with the balloon.
So the drug does the heavy lifting biologically, and the absence of the metal frame allows the vessel to just recuperate more naturally.
Precisely. This metal-free environment allows the vessel to, ideally, naturally remodel back towards its pre-disease shape, or at least a highly optimized configuration. What's really fascinating from a biological standpoint is that by eliminating that chronic metallic foreign body, DCBs eliminate those stent-associated maladaptive biological responses, that chronic inflammation we talked about.
Yeah.
And this seems to promote far more favorable, natural vascular healing over the long term.
Historically, though, DCBs were seen more as a tool of last resort, weren't they? Mainly for treating restenosis when a stent had already failed. What is this consensus changing about the recommended applications now?
Yeah, that's right. DCBs were already considered standard of care for managing end-stent restenosis, or ISR, whether it was from older bare metal stents or newer DES, and also for treating new lesions, de novo lesions, in very small vessels. What these new Asia-Pacific guidelines are doing is really pushing DCBs to the forefront as a provisional starting device in a much wider array of anatomies and patient types. They're positioning it as an equal or sometimes even a preferred alternative to putting in a DES right away.
Okay, and this transition brings us neatly to the unique context of the Asia-Pacific region, which seems to have been a major driver for this consensus document. The report highlights why DCB treatment might hold potentially greater clinical advantages there compared to, say, Western patient populations. What are those crucial demographic and anatomical differences?
Well, the differences are actually quite pronounced when you look at large studies. Angiographic data consistently shows that patients in the Asia-Pacific region often present with anatomically smaller coronary arteries on average. And critically, they also tend to have longer lesion lengths. This pattern is frequently characterized as small and diffuse CAD. And this diffuse nature, this widespread disease, is often exacerbated by a higher prevalence of conditions like diabetes mellitus in many of these populations.
So you're saying smaller plumbing, longer problems, essentially.
Yeah.
Which would make putting in long segments of metal stents intrinsically riskier from the get-go.
Much riskier, potentially. Those long, small vessels are highly prone to increased restenosis rates after stenting. But there's another major distinction, and it's pharmacological, related to patient risk profiles. Studies suggest that Asia-Pacific patients, as a group, often have a somewhat diminished baseline risk of outright stent thrombosis, the clotting issue.
Okay.
But importantly, they tend to have an elevated risk of bleeding events.
Oh, that distinction, lower clotting risk but higher bleeding risk, that makes the medication you need after the procedure absolutely crucial, doesn't it?
Exactly. Implanting a stent mandates prolonged dual antiplatelet therapy, or DAPT. That usually means 6 to 12 months, sometimes even longer, depending on the situation.
And DAPT is aspirin plus another agent, like clopidogrel or ticagrelor.
Correct. Combining those powerful blood thinners is necessary to prevent the stent from clotting up, especially early on. But that requirement significantly increases the patient's exposure to bleeding risk. Gut bleeds, brain bleeds, nuisance bleeding. Now, since DCB treatment leaves no permanent foreign body behind, it often requires a substantially shorter duration of DAPT. Sometimes, as we'll discuss, just 1 month.
Wow.
For a patient who's already at high risk of bleeding, this isn't just a minor advantage, it's potentially life-saving. Reducing that DAPT duration is a huge factor.
Right. So if the great promise of DCBs is this idea of leaving nothing behind, then it seems like the success of the entire strategy hinges completely on what happens before the drug-coated balloon even goes in. We're talking about something called optimal lesion preparation, or OLP. Why is OLP the absolute cornerstone here? And how is it different from just, pre-dilating the vessel before putting in a stent?
OLP is, well, it's the non-negotiable prerequisite. It's everything for DCB success. When you implant a stent, the main goal of predilation is really just to make sure the stent can get there and expand fully against the vessel wall.
Okay.
For DCB, OLP has two much more demanding functional mandates that have to be met perfectly. First, you have to achieve the maximum possible luminal gain and optimize coronary blood flow right then and there. And second, you need to meticulously condition the vessel wall itself. This often means creating controlled microdissections or cracks in the plaque. If that wall isn't properly prepared, meaning if we haven't adequately cracked the plaque and created pathways for the drug, then the drug simply won't transfer uniformly into the tissue or won't stay there long enough to work. And if that happens, you face either acute failure right away or a very quick recurrence of the blockage.
So what are the conventional tools that operators start with for this meticulous preparation?
The standard approach to OLP involves conventional angioplasty, but with specific parameters. Typically, it uses a semi-compliant or, more often, a non-compliant balloon. The consensus guidelines are very specific here. The balloon-to-vessel ratio must be 1.0.
Meaning you match the balloon size exactly to the vessel size.
Exactly. You size it precisely to the nominal or healthy vessel diameter. And, importantly, it must be inflated above its nominal pressure. You need to be quite aggressive to really treat the stenosis adequately and prepare the plaque.
And when the artery is, say, heavily calcified or really tough, that's when the more advanced tools come into play.
Right. When we face severe calcification or very fibrotic, tough lesions, operators need to deploy more advanced technologies. These can include things like ultra-high pressure non-compliant balloons, specialized scoring or cutting balloons, which have small wires or blades on them to create controlled cuts, or energy-based devices. These are things like rotablation, which is rotational atherectomy, like a tiny drill bit, or orbital atherectomy, which stands the plaque away, or even intravascular lithotripsy, which uses sonic waves to crack calcium. This aggressive plaque modification is often absolutely necessary to ensure the drug from the DCB can actually penetrate into the deeper layers of the vessel tissue where it needs to work.
But isn't there a risk of causing too much damage, too much injury with all that aggressive preparation? You mentioned that these advanced tools might actually carry a lower risk of severe dissection. How does that work? How do operators manage that balance?
It's all about controlled injury versus uncontrolled tearing. The reason advanced tools are often preferred in these tough lesions is because they enable a more predictable modification of highly resistant plaque. They tend to create those necessary cracks and fractures with a lower risk of causing a massive, uncontrolled, flow-limiting dissection compared to just trying to force a standard balloon through rock-hard calcium. The goal is really to crack the plaque circumferentially, around the vessel, not to cause a long, longitudinal tear down the vessel wall, which could be catastrophic.
Okay, this brings us to those two really strict criteria that act as gatekeepers. The guidelines say that after the OLP is done, after all that preparation, what are the two non-negotiable conditions that must be met before an operator is allowed to actually deploy the drug-coated balloon?
Yes, these are the hard stops. They're mandated by the Consensus for Safety and Efficacy. First, you must have achieved TMI flow grade 3. That's optimal blood flow. And second, the residual stenosis, the amount of narrowing left after preparation, must be less than or equal to 30%. So 30%. If the lesion preparation fails on either one of those points, if the flow isn't perfect or there's too much blockage left, the DCB strategy has to be aborted right there. The operator must then proceed immediately to provisional stenting to secure the result.
Let's break those down just a bit.
Okay.
What does TMI flow grade 3 actually mean visually or functionally for the patient's heart?
TMI stands for thrombolysis in myocardial infarction. It's a grading scale for blood flow. Grade 3 is the top score. It signifies normal, brisk flow through that segment of the coronary artery, just like in a healthy vessel. It means the preparation has successfully restored optimal perfusion, optimal blood supply to the heart muscle downstream. If you achieve that grade 3 flow, you know the mechanical job of opening the vessel is done well.
And why is that residual stenosis threshold set so precisely at 30% or less? Why not 40% or 50%?
The 30% threshold is based primarily on the risk of acute recoil and dissection propagation. If the remaining narrowing after your preparation balloon comes out is greater than 30%, there's a significantly higher likelihood that the vessel will immediately start to narrow back down, what we call elastic recoil, or that any small dissections created might actually get worse and limit flow. This immediate mechanical failure means the whole benefit of the DCB is lost before you even deliver the drug. So in that case, a stent is needed to physically prop the vessel open and maintain that luminal gain.
Now, you mentioned dissection earlier, the controlled injury. It sounds a bit counterintuitive, maybe, that we might actually want some tearing during preparation, but the report notes something fascinating, that Minor tears, these non-flow limiting dissections, often heal quite well after DCB treatment. Can you explain that nuance? It seems important.
Yeah, it is a bit counterintuitive, especially if you're used to thinking in terms of stenting, where any significant dissection is usually tacked down and sealed by the stent itself. With DCB treatment, however, the source material confirms that most non-flow limiting dissections, specifically those classified as less severe than a Type C dissection under the NHLBI classification, actually demonstrate quite benign healing. And interestingly, they often show positive remodeling, meaning the vessel gets slightly larger over time at that spot after the DCB delivers the drug. It seems the anti-proliferative agent helps to stabilize that minor injury and prevent it from causing problems.
So the takeaway for the operator is
The takeaway is crucial. Operators should resist the temptation to automatically implant a stent just to seal a small, non-flow limiting tear if the flow is good and the residual stenosis is low, because putting in that stent negates the entire leave nothing behind philosophy and the potential long-term benefits of the DCB approach. Don't overreact to minor dissections.
okay. And to make sure that optimal lesion prep is truly optimal and to confirm those strict criteria are met, the guidelines strongly advocate using imaging and physiological guidance, not just relying on the angiogram. How do tools like IVUS or FFR really help optimize the DCB delivery?
These tools are rapidly moving from being optional nice-to-haves to being pretty crucial for optimizing complex PCI, especially with DCBs. Intravascular ultrasound, IVUS, or optical coherence tomography, OCT, allow the operator to literally see inside the artery. They can visualize the plaque composition. Is it soft, fibrotic, calcified? And they can precisely measure the vessel dimensions, which is far more accurate than just looking at the 2D shadow on an angiogram. There's direct evidence for this too. The Ultimate 3 trial, referenced in the consensus, demonstrated that IVUS-guided DCB treatment resulted in significantly lower late lumen loss at 7 months, compared to just using angiography guidance. IVUS helps ensure you've achieved truly optimal OLP and that you select the correctly sized DCB.
And what about functional assessments like fractional flow reserve or FFR? How does measuring the physiology help?
FFR guidance is particularly useful for assessing the physiological success of the OLP, especially in larger vessels. For treating de novo large vessel disease, for example, the guidelines suggest that if the FFR value measured after the initial balloon angioplasty preparation is 0.75.
Okay, 0.75 or higher.
Then the DCB is deemed suitable. That 0.75 value essentially physiologically validates the mechanical result. It predicts favorable long-term outcomes and gives the operator confidence to proceed without needing to implant a metallic stent. It confirms the vessel is functionally open.
All right, let's turn to the actual drug delivery itself now. We've prepped the vessel perfectly. What are the critical elements of optimizing that local drug delivery? How important is that magic minute or 60 seconds of inflation, and what's actually happening pharmacologically during that time?
That minute, or really a minimum of 60 seconds, seems to be the critical contact time required based on current evidence. Remember, the drug, usually paclitaxel, is attached to the balloon surface by an excipient, a carrier molecule. The balloon inflation needs to be maintained for at least those 60 seconds, typically at the balloon's nominal pressure, to physically force a sufficient concentration of the drug into the deepest layers of the vessel wall tissue. It needs time to transfer effectively.
I can imagine in a high-pressure situation, maybe a complex case, operators might feel tempted to rush that inflation time. What are the measurable consequences if the technique isn't quite right? Is there data on that?
Oh yes, the consequences are pretty stark and have been measured precisely. Our sources, the consensus document, indicate that things like inflation delays, meaning waiting more than maybe 25 seconds after reaching the lesion before you actually inflate the balloon, or having an insufficient contact time, specifically less than 60 seconds. Each of those technical issues may increase the risk of target lesion failure, or TLF, by approximately 2.0-fold. So double the risk.
Double the risk of failure just from cutting the inflation short or delaying it. And just to clarify again for everyone listening, target lesion failure, or TLF, that's the key clinical metric we use to track adverse events after these procedures, right?
Right. Exactly. TLF is usually a composite endpoint. It typically includes outcomes like cardiac death, a heart attack related to the treated vessel, or the need for a repeat procedure, either another PCI with a stent or bypass surgery on that specific lesion that was treated. So if you rush the drug delivery technique, you could essentially double the chance of one of those bad outcomes happening down the road. Technique matters immensely.
And another technical point mentioned is avoiding geographic miss. I imagine that's kind of the equivalent of missing the target area slightly if you were placing a stent. How critical is that with a DCB?
It is critical, and it's actually an independent predictor of restenosis with DCBs.
Yeah.
Geographic miss simply means the drug-coated segment of the balloon fails to adequately cover the full extent of the diseased or injured area, including the edges where the preparation balloon might have caused some minor trauma.
So how do you prevent it?
To prevent this, procedural optimization requires the DCB to extend at least 2 to 3 millimeters beyond the predilated segment on both sides, both proximally and distally. That small margin ensures complete drug coverage of the entire treated zone. And again, this is often best verified using intravascular imaging like IVUS or OCT, rather than just relying on the angiogram to ensure you've covered the whole area properly.
Okay, let's shift gears now and look at how DCBs actually perform across various types of blockages, different lesion characteristics, starting with in-stent restenosis, or ISR. This seems to be the area where DCB first really proved its worth. Why is it considered clearly superior here, especially when you have restenosis forming inside an existing drug-eluting stent?
Right, ISR was the initial proving ground. When restenosis occurs inside a DES, what we call DSSR, you already have a layer of metal struts and likely some residual polymer coating that, for whatever reason, failed to prevent the tissue overgrowth. If your solution is to place another stent inside the failed one, you're creating a stent-in-stent situation. You're adding yet another layer of metal, which further compromises the vessel's natural mechanics, makes any future interventions in that segment exponentially more difficult, and increases the overall mechanical constraints and stiffness of the artery.
So the DCB acts like a rescue mission that doesn't compound the existing problem with more hardware.
Precisely. It delivers a potent anti-restenotic drug directly to that proliferative tissue, the scar tissue that grew back, without adding any additional structural burden. Multiple clinical trials over the years have established pretty clearly that DCB is superior to just using a plain balloon angioplasty again, and it performs comparably to putting in a second-generation DES for treating both ISR that occurs in older bare metal stents, BMS ISR, and the more challenging DBS IR. The DARE trial, for instance, specifically compared DCB to second-generation DES in this tough ISR setting. It demonstrated comparable outcomes in terms of the vessel opening, the minimal lumen diameter, and the need for repeat procedures, target vessel revascularization or TVR, up to 1 year. So when the vessel looks good angiographically after you've prepared the ISR lesion, DCB is now really the uncontested preferred method for treatment.
Okay, that's clear for ISR. Now, moving to new blockages, de novo lesions, specifically in small vessels, defined usually as vessels less than 3 millimeters in diameter. These have always been a bit problematic for stents, haven't they? Because there's just not much room for error or for any tissue growth after you implant the stent. What does the evidence show for DCB in these really tight spaces?
Exactly. Small vessels are challenging. DCB is highly effective here precisely because it maximizes the available natural lumen without leaving any metal behind to take up space. The pivotal trial here was Basket Small 2. This is a large, important randomized trial that directly compared DCB treatment versus implanting a second-generation DES for de novo small vessel disease. And what it found was that DCB treatment was essentially just as effective as the DES. The rates of major adverse cardiac events, or MACE-E, were comparable between the two groups over a 3-year follow-up period.
And MACE, just to remind our listeners, is that broad umbrella term that combines all the serious bad outcomes like cardiac death, heart attack, and the need for repeat procedures. So DCB performed equally well over 3 years in small vessels. That's impressive.
It was. But there was another trial, Picoletto 2, that provided perhaps an even more compelling mechanical reason for why DCB might actually be superior in small vessel disease, or SVD. That trial showed DCB was superior to DES, specifically in reducing late lumen loss, or LLL.
LLL, that's the measure of how much the vessel narrows down again months after the initial procedure, right? What was the actual difference found in Picoletto 2?
The difference was quite significant. The average LLL was only 0.04 millimeters for the DCB group, compared to 0.17 millimeters for the DES group at the 6-month follow-up.
Wow, that's more than a 4-fold reduction in that tissue encroachment or narrowing.
Exactly. This structural difference really highlights the advantage of having a completely metal-free environment in these already tight vessels. It allows the vessel to heal, it seems, without that chronic proliferative stimulus that even a modern stent might impart, potentially leading to better long-term patency.
Okay, this success in small vessels naturally leads us to the most contentious area, maybe the next frontier, de novo large vessel disease. We're talking vessels 3 aerometers or greater in diameter. This has traditionally been the absolute domain of the drug-eluting stent because, frankly, outcomes were historically excellent in these larger pipes. Is the DCB genuinely challenging this established standard now?
The challenge is very real, and is driven largely by that overarching desire to avoid the potential long-term vulnerability associated with permanent metal implants, even in larger vessels where acute results with stents are good. There's growing evidence supporting DCB efficacy here, too. For instance, studies using FFR guidance for DCB treatment in large vessels have shown significantly lower late lumen loss compared to DES. And interestingly, the physiological FFR values at follow-up were comparable. This suggests that DCB might allow for positive remodeling the vessel, gradually getting slightly bigger, and a gradual enlargement of the minimal lumen area over time, whereas a stent obviously remains a fixed size forever.
I mean, if DES performs almost perfectly in straightforward, non-complex large vessels, why should an operator consider switching to DCB? Especially given that DCB relies so heavily on achieving that perfect, sometimes difficult, optimal lesion preparation, isn't DES just simpler and more predictable in this setting?
That really is the crux of the current debate, and it's why the results of the Rec Cage-Free Eye trial, which were presented recently, introduced a significant note of caution. This was a large randomized trial specifically comparing DCB treatment, with the option for provisional rescue stenting if needed, against just going straight for intended DES implantation in non-complex large vessel lesions.
Right. And what was the conclusion from Rec Cage-Free Eye?
The headline result was that, at 2 years, the DCB treatment group failed to prove non-inferiority to the intended DES implantation group for the main outcome measure, the device-oriented composite endpoint, or DOCE.
Failed to prove non-inferiority. So, in simpler terms, the DCB strategy wasn't shown to be quite as good as just putting in a stent for these relatively straightforward large vessel blockages.
That's essentially it. For these less complex lesions, DES still appears to be the gold standard based on this trial. The results strongly suggest that even the occasional need for a bailout or rescue stent in the DCB arm because the OLP wasn't perfect or there was a dissection ends up negating the potential overall benefit and perhaps impacts the safety profile compared to just reliably putting in a stent up front.
So, we have a clearer picture emerging. DCB looks clearly better, or at least strongly preferred, in ISR and probably in de novo small vessel disease. But for the larger straightforward vessels, the debate is definitely ongoing, and DES likely remains the standard for now.
Exactly. That sums it up well. And that's precisely why we need to keep a close eye on the results from the major ongoing large vessel trials, specifically the reverse trial and the stentless trial. These are large, randomized studies designed to definitively compare the long-term outcomes of DCB versus DES, specifically for vessels 3.0 millimeters and larger. Their results will be crucial in settling this debate.
Okay, let's move to arguably the most complex anatomy operators face: bifurcation lesions. That's where a main vessel splits into a significant side branch. These are notoriously tricky, often with poor long-term outcomes after stenting. How does DCB potentially mitigate the complexity of treating both the main vessel and the side branch?
Bifurcation lesions are mechanically very challenging. Conventional stenting techniques, especially those involving 2 stents, often result in multiple layers of stent metal right at the carina, that crucial junction point where the vessel divides. This creates areas of disturbed blood flow and high stress, making them prone to restenosis. DCB is attractive here because it offers the potential to treat one or both branches effectively, while drastically minimizing this metallic burden at the junction. The PEPCAD-BAF trial, for instance, showed a significant reduction in restenosis in the side branch when DCB was used, compared to just using plain old balloon angioplasty, or POBA. The restenosis rate dropped from 26% with POBA down to just 6% with DCB.
So, is the standard approach becoming a kind of hybrid strategy? Maybe stenting the main, larger vessel and then using a DCB in the side branch if it's compromised?
That hybrid strategy is highly effective and is definitely gaining favor. The DCB-BIF trial confirmed this approach. It showed that stenting the main vessel combined with using a DCB for the compromised side branch resulted in a lower rate of composite adverse outcomes at 1 year compared to just using a simple non-compliant balloon in the side branch after main vessel stenting. Furthermore, other studies looking specifically at complex left main bifurcation lesions, a very high-risk area, have shown that using a DCB-based hybrid approach yielded lower late lumen loss and lower rates of target lesion failure compared to more complex double-stent DES-only strategies. So, optimizing the side branch with DCB seems beneficial.
Are there any specific procedural requirements when using a DCB in this junctional anatomy to make sure the drug covers the origin of the side branch properly?
Yes, procedural precision is vital here to avoid that geographic miss right at the ostium, or opening, of the side branch. The guidelines recommend that the DCB should extend about 4 to 5 millimeters back into the main vessel proximal to the carina, and also 2 to 3 millimeters distally into the side branch itself. This slightly longer overlap ensures complete drug coverage of those critical ostial segments where restenosis is most likely to occur in bifurcations.
All right, finally in this section on lesion types, let's briefly touch upon chronic total occlusion, or CTO, and also diffuse lung disease. These are situations that often demand what operators sometimes call a full metal jacket, long segments covered by multiple overlapping stents. Can DCB offer an alternative here?
Absolutely. CTOs, these completely blocked arteries, are often highly calcified and fibrotic. Successfully opening them via PCI often requires extensive vessel preparation, sometimes subintimal tracking, and frequently ends up needing multiple long overlapping DES to scaffold the entire segment. This, as we've discussed, creates an extremely high metallic burden, and those overlap points between stents are known major predictors of future adverse events like restenosis or thrombosis. DCB offers the potential ability to treat the entire open segment effectively without mandating that full metal jacket.
So when can a DCB be safely and effectively used after successfully opening a CTO? Are the criteria different?
A DCB-based strategy, either alone or perhaps combined with just a spot stent for a specific problem area, is considered promising and feasible, provided the optimal lesion preparation is successful. Specifically, you need to achieve that TMI flow grade 3 perfect flow, and interestingly, the consensus suggests a residual stenosis threshold of 50% might be acceptable here.
So slightly higher than the 30% for non-CTO lesions.
Yes, exactly. It's a bit more lenient, 50% versus 30%. This likely reflects the inherent difficulty of achieving a perfect result after crossing a CTO. The bar is lowered slightly, but you still need excellent mechanical flow restoration after the preparation phase before considering DCB.
Is there any situation where even if you get a good opening in a CPO, a DES is still strongly recommended instead of a DCB?
Yes, there's one crucial caveat, and it relates to the technique used to cross the occlusion. If the procedure required a subintimal approach, meaning the guide wire and devices traveled outside the original true limit of the vessel, in the space between the layers of the vessel wall to get through the blockage, then DES implantation is still the recommended default strategy, even if the final result looks good. The reason is we currently lack sufficient long-term evidence on the safety and healing dynamics of using a DCB in that structurally altered subintimal space. So the mechanical scaffolding provided by a stent is generally preferred for durability and to prevent late collapse in that scenario.
That makes sense. And just briefly, for diffuse lung disease or multivessel disease, where the main goal might simply be reducing the sheer amount of metal implanted across the coronary tree.
This is becoming a prime indication for a DCB-based strategy. When you have very long lesions or disease in multiple vessels, the primary objective shifts towards substantially reducing that overall metallic footprint and its associated long-term risks. A key study by Shin et al., highlighted in the consensus, demonstrated this benefit very clearly. They compared a DCB-based strategy, using DCB primarily with DS only provisionally, against a conventional DS only strategy in patients with multivessel disease. The DCB-based approach significantly reduced the total stent length implanted and, more importantly, resulted in a dramatically lower MA incidence, only 4% in the DCB group versus 11% in the DS only group over 2 years of follow-up. So in widespread disease, less metal clearly seems to translate into better long-term clinical outcome.
Okay, let's pivot now from the lesion anatomy to the patient themselves. Certain patient characteristics make them potentially better candidates for DCBs. Let's start with high bleeding risk, or HBR, patients. We know that bleeding after PCI significantly increases mortality and complications. How does DCB deliver potentially a life-saving advantage for these individuals?
Yeah, this is a really important group. The advantage for HBR patients is centered almost entirely on that critical issue of dual antiplatelet therapy, or DAPT duration. For patients already at high risk of bleeding, maybe they're elderly, have kidney failure, a history of ulcers, or need anticoagulation for other reasons, keeping them on aggressive blood thinners like aspirin plus clopidogrel or ticagrelor for 6 to 12 months, as required after a DES, is incredibly dangerous. DCB treatment offers the immediate possibility of discontinuing that second antiplatelet agent much sooner, sometimes after just 1 month, because there's no permanent implant left behind that's prone to acute clotting.
How short can that DAPT period actually be after a DCB? Is there solid trial evidence supporting very short durations?
Remarkably short, based on emerging data. The DEBUT trial provided some compelling early evidence. It compared DCB treatment against older bare metal stents, BMS, specifically in HBR patients. It found that DCB treatment was actually superior to BMS, showing a dramatically lower AC rate, only 1% in the DCB arm versus 14% in the BMS arm at 9 months, likely because BMS have high restenosis rates. But perhaps more relevant to DAP duration, another functional study showed that FFR-guided DCB treatment in HBR patients allowed for just 1 month of DEP. And importantly, despite this ultra-short DPED, the DCB maintains superior long-term vessel patency.
Right, diabetes poses significant challenges in PCI. DM patients tend to suffer from accelerated atherosclerosis. Their disease is often more widespread and diffuse, and their vessels exhibit impaired healing responses. This makes them particularly prone to restenosis after stenting, even with modern DES, although DES are still better than BMS. And as you mentioned, the diffuse nature of their disease often involves those small, long vessels, frequently requiring extensive metallic coverage if treated with stents, which, as we've already established, can lead to poorer long-term outcomes.
So the hypothesis is if you remove the chronic inflammatory stimulus of the metal stent, do their outcomes perhaps normalize or at least improve significantly?
The evidence suggests they improve quite significantly. A really critical subgroup analysis came from that large basket-small 2 trial we discussed earlier, comparing DCB versus DES in small vessels. While DCB was found to be non-inferior to DES overall in the trial, specifically within the subset of patients with diabetes, the DCB actually showed a significantly lower rate of target vessel revascularization, or TVR, meaning fewer repeat procedures on the treated vessel. The TVR rate was only 9% for DCB compared to 15% for DES at the 3-year follow-up point.
Wow, a 40% relative reduction in the need for repeat procedures specifically in the diabetic cohort. That's a very persuasive argument for considering the DCB approach in diabetic patients with small vessel disease.
It is indeed, and the potential clinical benefits were further solidified by that Her et al. Study we mentioned earlier, which specifically looked at diabetic patients with multivessel CAD. In that study, the DCB-based strategy, less metal overall, resulted in a MACE risk of just 2.9% compared to a much higher 13.9% in the DES-only group over 2 years. This strongly suggests that achieving the anti-proliferative effect without the chronic inflammation associated with metal might be biologically superior for managing diabetic coronary artery disease in the long run.
Okay, our final specific patient profile is the most acute setting. Patients presenting with acute myocardial infarction, or AMI, a heart attack. These patients typically have a high burden of clot or thrombus in the artery and need immediate flow restoration. Can DCB realistically handle that kind of urgency and complexity?
It can, potentially, but the application in AMI is highly provisional and very conditional. DCB can be used as an alternative therapeutic approach, but only if blood flow is rapidly and completely restored, TMI3 flow, and the underlying residual stenosis is minimal after aggressive thrombus removal, aspiration thrombectomy, and initial balloon dilation. The key prerequisite is that the lesion has to look relatively clean and widely patent after these initial steps.
And assuming you can achieve that good initial result, is the efficacy of DCB comparable to just placing a DES, even considering all the complexities of treating during an acute heart attack?
Several trials suggest it is non-inferior, meaning it performs similarly. The Revelation trial, for example, focused specifically on patients with ST elevation MI, or SEMI, the most serious type. It demonstrated that DCB treatment was non-inferior to DES implantation in terms of the physiological FFR values measured at 9 months follow-up. And for patients with non-STEMI, the PEPCAD and STEMI trial also showed that DCB was non-inferior to stenting, using either BMS or DES, in terms of the rate of target lesion failure. So the evidence does support considering it as an option, again, provided you can achieve that required optimal lesion preparation despite the challenging acute environment.
And what happens if the lesion preparation just isn't adequate? If the vessel still looks messy after thrombectomy and ballooning, or if there's clearly a high thrombus burden remaining? What's the default strategy then?
If those critical gatekeepers for DCB use are not met, if the flow isn't perfect, TMI3, or the residual stenosis is still too high, 30%, or if there's clearly a significant residual thrombus burden visible on imaging, then you absolutely must fall back on DES implantation. In those situations, the stent provides the necessary mechanical scaffolding to maintain vessel patency, compress any residual thrombus against the wall, and ensure a safe and durable result. The DCB strategy in AMI is always provisional. The DES remains the essential fallback necessary for patient safety when the initial prep isn't ideal.
Okay, looking ahead now. The success of current drug-coated balloons relies heavily on the specific drug used. Paclitaxel seems to dominate the DCB market, yet sirolimus and its analogs are clearly the drugs of choice for modern drug-eluting stents. Why is there this apparent discrepancy or debate? Why does one drug seem to work better when eluted slowly from metal, while the other works better with rapid delivery from a balloon?
Yeah, this is a fascinating pharmacological paradox, and it seems to relate primarily to a property called lipophilicity, basically, how well the drug dissolves in fats or lipids. Paclitaxel has proven excellent for DCBs, largely because it has very high lipophilicity.
Meaning it's very fat soluble.
Exactly. This high fat solubility allows it to penetrate the vessel wall tissue very rapidly during that short balloon inflation, and then it tends to persist within the tissue effectively, providing that anti-proliferative effect even after just a 60-second transfer time.
And sirolimus, which we know is excellent when delivered slowly from stents.
Well, sirolimus and its limus analogs generally have lower lipophilicity compared to paclitaxel. In a drug-eluting stent, this isn't a problem because the sirolimus is slowly eluted over weeks or months from the permanent polymer coating on the stent. It has plenty of time to gradually penetrate the tissue. But with a DCB, you need very rapid delivery and uptake within about a minute. Sirolimus's relatively limited ability to rapidly penetrate and then stick within the vascular wall makes successful delivery from a balloon platform much more challenging. It often requires more complex excipients, carrier molecules, or nanotechnologies to try and enhance its transfer and retention.
Has there been a direct head-to-head comparison, a showdown between these two drug types on balloon platforms in a major trial?
Yes, the Transforma trial was a really critical study addressing this directly. It compared a sirolimus-coated balloon, or SCB, specifically the Magic Touch balloon, against a well-established paclitaxel-coated balloon, or PCB, the Sequent Please Neo, in patients with small vessel disease. The primary outcome was angiographic net gain at 6 months, and the result was that the SCB failed to achieve non-inferiority compared to the PCB.
Failed non-inferiority again. So the sirolimus balloon wasn't shown to be as good as the paclitaxel balloon in that trial, specifically for the angiographic outcome. That seems like a fairly decisive win for paclitaxel in the DCB category, at least based on that evidence. But why? What was the reason given?
Well, the primary driver for the difference in net gain was actually a fascinating biological phenomenon. It turns out the paclitaxel-coated balloon group had a significantly higher incidence of something called late lumen enlargement.
Late lumen enlargement. Wait, that sounds like the treated part of the vessel is actually getting bigger over time, not smaller.
Right.
Why on earth would a drug designed to stop growth make the vessel enlarge?
It's a somewhat paradoxical effect, but it's thought that the higher tissue concentration and perhaps the longer persistence of paclitaxel delivered by the DCB not only effectively prevents the negative remodeling, the scarring and narrowing, but it might also encourage a gradual, favorable, positive remodeling of the treated segment. The vessel wall actually expands slightly outwards, away from the lumen center, over the months following the procedure. This positive remodeling effect, which leads to a larger final lumen, is obviously highly desirable from a clinical standpoint. And it seemed to be more pronounced with the paclitaxel balloon in the Transformi trial, giving it the edge over the sirolimus-coated balloon in terms of the net lumen gain at follow-up. It's an area of ongoing research, this differential remodeling effect.
It's clear that DCB research is really accelerating now to address all these complex questions around drug delivery, optimal technique, and the right patient and lesion selection. What are some of the major unanswered questions currently being addressed by the big ongoing randomized controlled trials, or RCTs?
Yeah, the research landscape is incredibly active right now, really trying to solidify the role of DCBs across the entire spectrum of CAD. As we mentioned, we have major trials like reverse and stentless underway, specifically aimed at resolving that large vessel debate, trying to definitively determine if DCB is truly non-inferior, or maybe even superior in some aspects, to the best DS in vessels 3 millimeters and larger. Then, for those crucial high bleeding risk patients, trials like DCB-HBR in debate are rigorously testing the safety and efficacy of those extremely short, potentially 1-month DEPT regimens after DCB treatment. This is critical for expanding safe usage in that vulnerable population. And importantly, for the sirolimus balloon technology, we're eagerly awaiting results from trials like Transform 2 and Solution de Novo. These will further investigate SCB performance, often comparing them directly against the best current DES, particularly in small and medium-sized vessels, to see if newer SCB formulations can overcome the challenges seen in Transform 1. This huge scientific investment really confirms that DCB technology is seen as a major part of the future of PCI.
And all of this research, all this focus on minimizing or eliminating metal, points towards that ultimate goal, which we've sort of been discussing conceptually throughout this deep dive, the idea of truly metal-free PCI. Now, we have seen attempts at this before, most notably with the early bioresorbable scaffolds, or BRS. How does that earlier, somewhat troubled attempt factor into this modern vision?
That's a great point. The concept behind BRS was, in theory, perfect. Provide temporary mechanical scaffolding to support the vessel during the initial healing phase, deliver an anti-proliferative drug, and then have the scaffold completely dissolve over a couple of years, leaving nothing behind. The goal was precisely to overcome those chronic issues associated with permanent metallic implants that we've talked about. The chronic inflammation, the risk of neotherosclerosis years later, the compromised natural vasomotion of the vessel. However, as we know, the first-generation BRS largely failed because their bulky structure and mechanical properties were inferior to contemporary DES. This led to higher rates of complications like scaffold thrombosis and ultimately resulted in their early withdrawal from widespread use.
So, in a way, the failure of those early BRS actually fueled the urgent need for a different, more robust, non-scaffolding approach to achieving the leave nothing behind goal, an approach like the DCB.
Precisely. The success and rapid adoption of DCBs, particularly in areas like ISR and small vessels, really validates the core philosophy of minimizing or eliminating permanent implants whenever possible. But the original BRS concept itself is not dead. The expectation is that new generation BRS are currently under development, benefiting immensely from the lessons learned from the first generation, potentially with thinner struts, better materials, and more predictable resorption profiles. It's anticipated that these improved BRS, perhaps used strategically in combination with DCB innovation, may be using DCB to treat vessel segments proximal or distal to a short BRS segment that needs scaffolding, will eventually pave the way for a new, robust, and reliable era of predominantly metal-free PCI. This could fundamentally change how we approach treating almost all forms of coronary artery disease in the future. #tag outro. So we boil it all down, the key takeaway from this second Asia-Pacific Consensus Group report is really that the role of the drug-coated balloon has been permanently redefined. It's clearly moving away from being just a niche, specialized device for specific problems like ISR or tiny vessels, towards becoming a default, provisional device that should be considered upfront across a significantly broader spectrum of coronary artery disease. This major shift is driven fundamentally by its unique ability to significantly reduce the overall metallic scent burden in patients, and also, critically, by its potential to drastically shorten the necessary duration of dual antiplatelet therapy. That DAPT aspect offers particular safety benefits, especially in those high bleeding risk patients we discussed.
That really is the essential synthesis, isn't it? This deep dive clearly shows that the focus in interventional cardiology, or at least a major part of it, has fundamentally shifted. It's moving away from just perfecting the permanent device we implant, the stent, towards perfecting how well we prepare the vessel before we even decide what device, if any, is truly required in the end. It feels like we're trading the certainty of long-term metallic presence for the necessity of procedural perfection up front. So, given the weight of the evidence we've just reviewed, here's the provocative thought we'd like to leave you with. How long will it be until optimal lesion preparation, that meticulous vessel prep, guided rigorously by advanced imaging like IVUS or OCT, and confirmed by physiology like FFR, becomes universally recognized as the single primary metric of a successful coronary intervention, perhaps even more important than the choice of the final treatment device itself? Something to think about. Thank you for watching The Funnel Effect.